Hello there. So, today's session we are going to be talking about schizophrenia, and we are going to cover the following objectives: to understand the symptoms of schizophrenia, the biological factors contributing to schizophrenia, understand psychological factors of schizophrenia, and evaluate a couple of treatments of schizophrenia. Although we'll definitely go into more detail on schizophrenic treatments in another session. Just a disclaimer to begin with, this session is not medical advice for depression, low mood, or indeed psychosis. And if you know anyone experiencing depression, then please speak to the pastoral team or a member of staff. So, what do you know about schizophrenia and what causes it? So, previously we've spoken about depression, which may have serotonin implicated in its pathology. Many diseases within the mental health field have issues in neurotransmission deficits, either too much, too little, issues with transport, issues with depolarization of the axons, or issues with myelination and connectivity between regions of the brain. All of these are involved within schizophrenia, and it is an incredibly complex biological phenomenon. We are going to be focusing today on the dopamine pathway, as it is the primary hypothesis within schizophrenia. So, like all neurotransmitters, dopamine is tightly regulated through various different facets, including its synthesis, release, breakdown in the synaptic cleft, reuptake and cycling of it, receptor binding and release and receptor levels, and the receptor response on downstream signal transduction. Each of these can be regulated and require equilibrium for correct functioning. And indeed, when this equilibrium is altered, then that is what often is associated with behavioural consequences. So schizophrenia itself is associated with three symptoms clusters. These are positive symptoms, negative symptoms, and cognitive symptoms. Positive symptoms are things that are added to the disorder, and these include delusions, hallucinations, false beliefs, auditory hallucinations, rapid changes of subjects, and use of invented false words. These are the things that people typically think of when we think of schizophrenics. It's also of note that schizophrenia is one of the most stigmatized illnesses as a result of media portrayals of positive symptoms, such as the violent schizophrenic or a schizophrenic who kills people, when in reality, schizophrenia is often a tragic infliction upon individuals, and people with schizophrenia tends to be often on the receipt of such dire treatment, and indeed may sadly end their lives. Negative symptoms of schizophrenia include the loss or reducing of functions such as reduced speech, social withdrawal, anhedonia, and then of course cognitive impairments are rampant within schizophrenia. These include impairments within cognition of working memory, spatial memory, attention, and executive functions, which we see across a range of mental illnesses. Now, the life course of schizophrenic patients varies vastly, and schizophrenia is a sort of late adolescence, early adulthood presenting disease, although there is a pre-adolescent schizophrenic stage, sometimes called the prodrome, where some of the early functional impairment can begin to become visible. And indeed, in individuals with schizophrenia, sometimes cognitive deficits can be seen as early as primary school. So to look at these groups individually, we have one group of people who have one episode of psychosis and then have no issues after that, and that's about 22%. The second group have several episodes with minimal impairment, that's about 35%. The third group have impairment after the first episode and no return to normality. And then the fourth group, who have the most difficult time, have repeated episodes and no return to normality at all. So as we can see, there is a varied life course of those with schizophrenia, showing the range of severity within the symptoms of the disease. Dopamine within the brain is important, and within today's session we'll be focusing on the mesolimbic and mesocortical pathways. And it is an increase in dopaminergic neurotransmission of the mesolimbic pathway, which is commonly associated with schizophrenic symptoms. This is thought to contribute specifically to the positive symptoms. Now, it should be noted that Increase in dopamine within the mesolimbic or reward pathway contributes to the positive symptoms, and decreases of dopamine within different regions of the brain, including the prefrontal cortex or the mesocortical pathway, is associated with those negative and cognitive symptoms. So it's not just a global increase of dopamine throughout the brain, but rather a mixture or a site-specific change within the dopamine signaling of the brain. Now, what causes those site-specific changes of dopamine is not fully understood, but there are a few contributing factors that we will discuss. Now, there is many lines of evidence for the dopamine hypothesis, including the observation that dopamine antagonists reduce positive symptoms of schizophrenia, and this came from the 1950s. Increasing dopamine metabolites within patients can also leads to positive symptoms, and PET scans, which are scans of the brain looking at patients who are prescribed amphetamine, which releases dopamine, increases the severity of positive symptoms, amongst others. Looking at that dopamine hypothesis in a bit more detail, Howes et al. Looked using the PET scanning technique that we just discussed, using a radioactive tag to visualize dopamine synthesis, and show that there is a greater level of dopamine synthesis within schizophrenic patients, and this correlates with the positive symptoms. So antipsychotics, which are the primary drug that we use, also support the dopamine hypothesis. So studies which look at antipsychotic drugs which specifically bind to D2 receptors find that they reduce the positive symptoms. The role of dopamine within schizophrenia was strengthened by the finding that all such antipsychotic drugs, at least in the primary wave of antipsychotics, bind to the D2 receptor. And the efficacy of antipsychotics is closely correlated with the ability to bind to the D2 receptors. However, there are exceptions to this rule. Clozapine, which is a different class of antipsychotic, actually has a lower binding affinity for the D2 receptor. However, is commonly regarded one of the most effective antipsychotic drugs. So that last piece of evidence about clozapine and its weaker binding to the D2 receptor to reduce dopamine levels actually suggests that dopamine is not the whole story when it comes to treating schizophrenia. So looking at clozapine, there seems to be what we call a therapeutic window, where if there is a binding of between 60 and 80%, then to the D2 receptor, then symptoms are relieved. However, outside of this window, too low, then the symptoms are not reduced, and too high, then we begin to initiate Parkinsonian movements, where the nigrostriatal pathway, which requires dopamine to allow movement coordination, becomes affected negatively and leads to issues with movement and control there. So, going back to the age-old question, where does this dopamine activity excess that we see within schizophrenia actually come from in the first place? And there are quite a few different contributing factors, including potential variants of the D2 receptors. There is a genetic component of schizophrenia. Many contributing genes contribute to schizophrenia, and some of which are associated with variants within the D2 receptor. Stress early in life can epigenetically alter genes and alter the development of the brain, and thus lead to excessive dopamine activity. This may lead to the dopamine not being metabolized properly within the synaptic cleft, leading to it to be at higher levels within the mesolimbic pathway. And also stress within adolescence is particularly important. Schizophrenia often begins on the onset of late adolescence, between 18 and 25, when the prefrontal cortex is going through its final waves of pruning and development. And stress during that time has been shown to be a risk factor for schizophrenia due to the lack of dopamine that is going to end up being present there. However, as I've said, dopamine is not the whole story. Many schizophrenics do not respond to antipsychotic drugs. It is a highly heterogeneous condition. One explanation is that people with schizophrenia don't all have the exact same underlying neurological disorder. Some PET scans show that those who do respond to dopamine antipsychotics have a higher dopamine synthesis capacity, whereas those who do not respond do not show the same elevation, suggesting a heterogeneity or differences between people with the same disorder, and thus different treatment should be considered. In treatment-resistant patients using MRI treatment, responders have normal levels of glutamate, but treatment-resistant individuals have higher levels of glutamate. Now, glutamate is the main excitatory neurotransmitter within the nervous system, and glutamate itself is a regulator of dopamine. Higher levels of glutamate can lead to higher levels of dopamine, but through different pathways than direct dopamine synthesis. And this evidence suggests that those with treatment-resistant schizophrenia may not have marked issues with their dopamine synthesis, but rather the defective glutamate transmission, suggesting it has an important role within the disease in some people. Other neurotransmitters are also involved beyond dopamine and glutamate. These include GABA, which regulates glutamate and dopamine, often found in lower levels within individuals with schizophrenia. Serotonin, which modulates dopamine and is inhibited by GABA. And as a result, such varied contributing factors can lead to schizophrenia having wildly different symptoms, and therefore wildly different treatment avenues that may be effective. Glutamate is regarded to be involved within the negative symptoms of schizophrenia. So normally, sufficient dopamine reaches the cortex of the brain, the prefrontal cortex, whereas in schizophrenia there are overactive cortical projections due to deficiency of GABA, which usually inhibits the dopamine and the glutamate. This leads to hyperactive GABA. This blocks the dopamine within the mesocortical system and leads to less dopamine in the prefrontal cortex. And less dopamine in the prefrontal cortex is associated with things like hypofrontality, the lower ability to think, the lower ability to plan. So that is another potential role of glutamate. In the next session, we will be discussing how exactly we might go about treating schizophrenia.